The coronary angiograms typically performed with a local anesthetic?
Yes.
Okay. Now, I was knocked out during this procedure, and I noticed that the report indicates that 25 micrograms of fentanyl and 1.5 milligrams of midazolam were used. I understand that this is a higher level of sedation than is typical of local anesthesia. Is that correct?
Yes. So midazolam is a sedative, right? So we would normally just give a little bit of lignocaine locally.
I see.
And that's what we typically do. But midazolam is quite a strong sedative.
Would that amount of medication be sufficient to render the patient unconscious?
Sure, it could make you very sleepy.
Yeah.
And that is quite a lot. It's quite a lot. Fentanyl and midazolam.
I was out.
Yeah.
I was totally unconscious. They did a CT angiogram before this, the same day, where they analyzed the valve itself closely.
Did they not look at your coronaries during the CT coronary angiogram?
I understand they did that too, but the results were not disclosed.
Why did they need to do the coronary angiogram?
Exactly. He initially actually denied performing a retrograde left heart catheterization. He said he didn't go anywhere near the aortic valve initially. Right? He said he just did a coronary angiogram. So
that clearly is false, because he's definitely been in your aorta. He's been through your aortic valve. No doubt that there was instrumentation of your aortic valve. No doubt about that at all. Because it's written at 347, they said pull back from left ventricle to aorta.
yes.
347-16, pull back from the left ventricle to the aorta, 12.2 millimeters mercury gradient. So they were definitely in the left ventricle.
Another interventional cardiologist has told me that, in his words, they were playing with fire, and crossing that faulty valve with any kind of instrumentation was extremely dangerous.
I think, particularly with the right capsule are quite sharp. I can see how that could be something that could injure your valve, Definitely don't want to do it. Certainly not with the right. Your problem with your aorta was not the fact that there was a problem with it opening. The problem
Closing.
with your aorta was there was a problem with it closing, right? So when the aorta is open, it would easily accommodate the catheter to go in.
Okay.
The problem is when you pull it out.
When you pull it out.
If you've got a tip which is sharper when you pull it out. Peak-to-peak gradients, which are what you get when you stick the catheter in and then pull it back.
Well, if that was the case, it would be multiple pullbacks then.
Yeah, I guess so, because they're saying that they did that at 347.08, and then they've done that again at 347.16.
The purpose of these pressure gradient measurements is to determine the severity of aortic stenosis. Is that correct?
Yes.
Right.
And you don't seem to have any aortic stenosis. What I'm not understanding is why they're interested in measuring the gradient across your aortic valve when you never had aortic stenosis anyway. Your problem was lots of aortic stenosis.
Right.
There's no pigtail catheter listed in the procedural details.
Really?
But you would ordinarily use a pigtail catheter. It is considered the safer catheter to use, largely because I think in some ways a pigtail catheter is a safer catheter to use to get into the left ventricle. Because the other ones are more pointed, you see, because you have to cannulate the artery, whereas a pigtail is curled, so it's not so sharp, so to speak. But
Sure.
It is considered the safer catheter to use.
The normal pre-procedure blood pressure of 123/63 with a heart rate of 100, would that indicate that the heart was able to maintain cardiac output sufficient to prevent organ failure in spite of the high LV-EDP?
Yeah, your left ventricular output would be good, simply because there's so much volume. So even though your LV-EDP is high, the fact that your blood pressure is good tells you that your peripheral organs should get all the blood. The LV-EDP is significant in that the higher the LV-EDP, the more difficult it is going to be for blood to come from the lungs into the heart.
Yes.
An elevated LV-EDP has an impact on the lungs and may cause congestion in the lungs, but will not really have a major impact on your kidneys, etc., liver, etc.
In the event of further injury to the aortic valve, one would expect that LV-EDP to significantly increase?
Yeah, I mean, if you damage the aortic valve, then the LVEDP would go up significantly.
The start blood pressure was 127/63, and the end blood pressure was 95/46. Could that diastolic be an indicator of some additional damage to the aortic valve?
There's quite a lot going on at this stage. When you have the procedure and then you start deteriorating, diastolic would fall in aortic regurgitation. There is no doubt that your deterioration is something that has to be taken with great seriousness, right? What I don't understand is why people would disbelieve that when you've got a young guy who is now showing objective signs of something going wrong. Ingestion, how you are, and your liver function test. That's all pointing to something bad happening in the body.
We're talking about hypotension, lack of blood flow to the liver in this case, right?
Yeah, there are two mechanisms by which you could sustain liver damage in this context. Number one, your heart is not pumping much blood out because your valves have become more leaky. Less blood goes to all organs of the body. The kidney, the liver gets less blood, the liver becomes injured. That's one mechanism. Another mechanism is blood isn't coming out of the heart, so the blood is not getting into the heart because the heart is already full.
Exactly.
Blood. And therefore there's a back pressure. Remember, blood comes from the lungs, the blood comes from the legs.
I got it. The whole thing full,
to the heart. So if the heart is already full, the blood can't get into the heart, which means it congests in the lungs, causing the pulmonary edema, but equally well it could congest in the liver, causing liver damage.
Now, the cardiologist stated to the College of Physicians after the fact, the patient, meaning me, describes breathlessness immediately following the angiogram. He felt that the aortic valve had been severely ruptured and that he required emergency surgery. To perform coronary angiography does not require crossing of the aortic valve. There were concerns by the nursing and medical staff of anxiety as potentially a cause of the symptoms. Do you acknowledge that this statement could prevent a patient like me from receiving emergency care? Given that there's no acknowledgement of the procedures crossing the aortic valve. In fact, sort of a denial.
Yeah, I mean, I think you're right. I mean, I think that it doesn't all fit. But I just don't understand why they would choose to disbelieve you when the objective markers were indeed with someone who had deteriorated after the procedure. And the other thing, of course, is, your LVEDP is high, so I'm not sure why they would say that it's anxiety.
They actually arranged BUN to CR tests in advance of this very procedure. They didn't tell me that they were actually tracking what was happening. Vyselaar looked over his shoulder and he saw these lab readings, these urea readings in the 4 days following this procedure. He understood everything in one go because the urea to creatinine level spiked, and my ALT went from 100 to 1,000 before surgery. For 4 days, I was in the most astonishing, from what he's verified, cardiogenic shock, incapacitated, not able to move, with my lungs rapidly filling with fluid. Because I reported shortness of breath at rest right after this undisclosed angiogram. Nothing was done. I was offered a cough drop, and the following day I was given a chest x-ray that wasn't disclosed, which confirmed developing interstitial pulmonary edema, congestive heart failure, the start of congestive heart failure. I couldn't move, and I was vomiting repeatedly, and Vyselaar confirmed that they're actually tracking it through these lab readings. Now, on the 18th, 2 days after this procedure, the cardiologist said, stable for now. Shortness of breath associated with stress, not heart failure. And when he saw that, he was like, well, that's where we get into problems, because obviously the findings are there.
If there's interstitial pulmonary edema, then you cannot say it's due to stress. It is irrefutable.
It's irrefutable, and for what he said too, they could hear it developing on the lungs. So if they didn't have the chest x-ray, they would have heard it. On the 19th, 3 days after this, given what this cardiologist had said, they arranged an unsolicited psychiatric consult. I have no history of mental illness or anything like that. He said, we're not going to provide you care unless you see a psychiatrist. The psychiatrist came in. I'm completely incapacitated at that time. As you mentioned, the renal function documented in the labs. I can't move, and I'm being asked to describe my relationships with women and mood state. It sounds like a movie, but it actually happened. Surgery wasn't arranged until an hour after the psychiatric consult for the following day. So by the time I entered surgery, I was like unconscious. I have no memory waking up that day. I was in complete cardiogenic shock, total organ failure. As you can see, before this undisclosed procedure, there were no complications. I had a normal operative risk quote of 1%. I entered surgery in diabolical condition and was expected to die during the surgery. And I have a recorded consult with Vyselaar that confirms all these facts. So he basically went through the chart, determined like you did exactly what happened.
The handling of it was wrong in the sense that, you say, okay, well, this is what happened and this is why you've deteriorated.
They get paid per procedure, so there's an economic reason for doing these things. And in BC, it's called the fee-for-service model, so they get paid per procedure. So the angiogram has a billing code. The retrograde left heart catheterization has a billing code. So it was Vyselaar glancing at blood readings and seeing something catastrophic and saying, well, this happened, but I don't know why this would happen if you just underwent a coronary angiogram. Did they measure pressure gradients? So he scans through and it's like, okay. And it went from there. And so then it went to the billing department, medical billing department, and that led to an admission from the cardiologist in question that, yes, he had in fact performed this additional procedure. So it's just a big cash grab, non-disclosures and everything else. And that's the nature of BC Canada.